A very good afternoon to all of you and a warm welcome. Today, on behalf of our Department of Neurosurgery, All India Institute Medical Sciences, Delhi, in the clinical grand round today, we are going to discuss the saga of bloodless war against complex brain lesions. So it was the 1950s when the great neurosurgeon, researcher, innovator Lars Lexell, he conceptualized the idea of bloodless operations. He wanted an aesthetic scene, a bloodless operative field, and that is how the birth of Gamma Knife happened. That was the era when there was 60 to 70% mortality that was happening in neurosurgery, and the morbidity also was very significant, both for the operating surgeon with long, tedious hours of surgery, and the outcome in general was not very good. To today's era, where we have shifted into a more innovative world, with a tech-savvy world, where the outcome is not so grim, yet the Gamma Knife has stood the test of time, and it still holds that importance in our life. And through the coming slides, this is how the workflow of today's clinical grand round going to be. We're going to start with the case presentation and take you through what is actually the Gamma Knife radiosurgery and give an overview of how we have been working over the years, last more than 25 years at AIIMS Delhi in Gamma Knife. May I now welcome Dr. Pavna, who will take you through the case presentations.
Thank you for the opportunity, ma'am. Good evening, everyone. Let's begin our discussion with a few complex and interesting cases which were given primary gamma knife therapy at our center. Their clinical presentations, imaging features, gamma knife planning, and reporting. Through these cases, we would like to emphasize on the significance of gamma knife radiosurgery in the field of neurosurgery. Coming to our first case, is a 13-year-old female who presented to us with headache and seizures for past 1.5 years, which was not controlled on medication, and right-sided weakness. On examination, the child had right-sided hemiplegia, power was about 3/5 in both upper and lower. Her DSA imaging showed deep-seated AVM in the left thalamopedunclar region with multiple feeders from bilateral posterior choroidal arteries, bilateral anterior choroidal arteries, and left superior cerebellar artery with multiple venous pouches and drainage into the deep venous system. On MRI imaging, it suggested a large left thalamopedunclar AVM, Splatzer-Martin grade 5, with with a large annulus size of more than 6 centimeters. This is the comparative MRI, pre-treatment MRI with 2 years follow-up MRI, T1 rated with gadolinium enhancement, showing a large SM grade 5 AVM with deep drainage into the deep venous system. As you can see, we had planned primary gamma knife for this case with a treatment dose of 20 grays at 60% isodose. The usual dose for AVMs which we give is 22 grays at 50% isodose. In the follow-up scan, you can see that the lesion has almost disappeared without any radiation changes, post gamma knife radiation changes. This gamma knife plan had a coverage of 88% with selectivity of 0.85 and gradient index of 3.26. Coming to our next case, which was a 30-year-old male who presented to us with diplopia on left lateral gaze for the past 3 months and also subtle lower cranial nerve involvement. On examination, his visual acuity was 6/9 bilaterally with left 6 cranial nerve palsy with left-sided lower cranial nerve involvement. His MRI was suggestive of large left glomus jugular. According to Glasgow-Jackson classification, it was type 4, which had both intra and extracranial components. This patient was also planned for primary gamma knife therapy with a treatment dose of 25 grays at 50% isodose. This is the comparative, long-term comparative scans. The patient was treated at 2014. In 2014 for the large left-sided glomus jugular tumor. And this is the follow-up scan after 10 years, which shows significant reduction in the tumor size from 25 cc to around 9 cc at 10 years follow-up. These are the serial imaging follow-up imaging scans of the same patient, showing both intracranial and extracranial component. And the extracranial component has almost disappeared. Coming to my next case, which is the 52-year-old female patient who presented to us with headache for the past 6 months. On examination, visual acuity on the left eye is 6.5 and right eye is normal. She did not have any extraocular movement deficits. Her facial sensations were normal. No other deficits were seen. On imaging, she had a large cavernous sinus lesion, hemangioma. Cavernous sinus is usually considered as a no man's land, was used to be considered as a no man's land due to its complexity of and a lot of challenges due to its complexity and difficulty to access due to proximity to the most important neurovascular. But with the evolution of gamma knife, we had planned for primary gamma knife therapy for this patient with a treatment dose of 24 grays at 50% isodose. And this is the serial, this is the follow-up imaging of the same patient after 6 months. As you can see in the imaging, that the tumor had almost melted away or disappeared at 6 months follow-up. And patient does not have any. Now, I would like to call upon Dr. Sharanya from the Department of Radiation Oncology to show some light on radiation.
Thank you. Good evening, respected faculties and colleagues. So, I believe in radiation biology. Coming to the basics of exam, the word stereotactic radio surgeries in itself is derived from the Greek word stereo, which is a three-dimensional approach, which means tactile crash. Itself can be defined as an radiation technique that uses computer-calculated three-dimensional properties, usually for intracranial targets, delivering a high power of transmission, usually more than 10 bit sensitivity, using multiple non-coplanar photon radiation beams for the lab-based delivery system or radiation from multiple coaxial sources for the gamma-based delivery system with extreme precision, usually to the The technology advancements in the 21st century have now enabled us to deliver complex and high dose delivery. And the four pillars of exercise include immobilization, advancements in imaging, precise radiation delivery systems, as well as computerized dose planning. In the AIIMS, it is from the last lecture to the part of exercise. The key requirements for optimal stereotactic radiation include a smart target function volume, which is well defined and sharply defined, with accurate radiation delivery systems ensuring a high conformality. This ensures that a high radiation within the target volume with the key dose gradient with minimal dose relation to the normal tissue, so that there will be no rate. It is also essential that sensitive structures like optic nerves or spinal cord, brainstem, etc. are well away from our family target. Coming to a brief principles of physics in SIS. So, this figure here shows a conventional figure A. It shows a conventional treatment technique wherein a two-grade beam, which is on, will be delivered equally for the primary target as well as the surrounding normal tissue. The same beam, when we are actually dividing into multiple narrow beamlets, it can ensure that the tumor will be receiving a higher dose, approximately 8 grade, whereas the surrounding normal structure will be receiving a much less. Here are the aspects include non-coplanar beam delivery, multiple axis centric delivery, terminating in a dose like this. So for a target, with a gamma knife SLS, we are able to deliver a very high dose with very high conformity, whereas in the conventional radiation treatment, we can see that there is high dose radiation in the surrounding body. Coming to the radiological aspect, the success and failure of treatment plan, especially for conventional treatment plan, can be actually explained by the art of radiology. But these quintessential components cannot be actually extrapolated to SRS delivery system because SRS is being delivered in a single sitting. There is no time or treatment gap for the oxygenation disorder or information. The radiology of SRS can be divided into direct effect and indirect effect. Direct effect, it includes the direct DNA damage with the respective immunities. And indirect damage is by vascular and electrical damage as well as enhanced anti-tumor immunity. When we focus on this diagram, you can see when we are giving a high radiation dose, like more than 10 days in a single sitting, this will activate this enzyme. This active chemomyelin, the enzyme which actually converts the chemomyelin in the plasma membrane of the endothelium into ceramide. This ceramide will activate that. This is a BSCL2 family of a prototype protein, which will actually transfer the cytochrome C from the mitochondria into the cytoplasm, which will commit the pathway into apoptosis. So, when this occurs, there will be a microvascular dysfunction which causes an acute destruction of chemoproliferation. Furthermore, when the doses are escalated to more than 17 days, we can see that the ceramide synthase is directly activated, which will produce the ceramide and going along the same pathway. This here shows the direct effect. When we are getting a high concentration, it directly causes the DNA damage with the The other method is enhancing the anti-tumor immunity. When we are actually focusing on this graph, we can see that in the y-axis there is the antigen release, and in the x-axis is the escalation of the proliferation. When we are actually giving the conventional radiation dose, it does not actually have does not enhance the immunity system. But when we are doing a high dose of radiation, there will be a geometrical increase in the antigens that are released from the tumor, and this actually go on to activate the T cell response, which again further increase the antigen release from the tumor, going back into a vicious cycle. So in the immune ablative dose, we have actually got an anti-tumor immune enhancement. Coming to the external delivery system, we have gamma-based as well as based systems, and the most recent gamma delivery systems are perfection as coming to the indications. SRS can be given for both benign as well as benign disease. So benign disease like AIIMS, trichomoniasis, pituitary adenoma, and for primary as well as secondary disease in brain, including primary glioma as well as and these are the safety limits highlighted as well as process, which has to be also has to be on the issue. Thank you.
So, good evening, everyone. Today we will touch upon the radiation physics and the basics of how the gamma knife functions. So, from radiation point of view, what is radiation? The term radiation applies to the emission and propagation of energy through space or metal medium. Radiation can be in the form of particles or EM radiation or both. Type of radiation like radioactive in the form of radioactive source, which is used for over 60 base gamma rays in gamma knife, and Bremston X-rays, which is used the base for linear accelerators, charged particle beams in the form of proton therapy and carbon ion therapy. According to the radiation principle, when X-ray gamma ray pass through a medium, interaction between photons and matter can take place, resulting in transfer of energy to the medium. Initial process in interaction is ejection of electrons from the atoms. These high-speed electrons transfer the energy by producing ionization excitation. Interaction can be further classified based on inelastic collision with atomic electrons, inelastic collision with nuclei, elastic collision with atomic electrons, and elastic collision with nuclei. Coming to the gamma knife design, it has the multiple sources arranged in hemispherically pattern, and the cobalt 60 sources emit gamma rays, which convert at the center of the unit, which is called the isocenter, the unit center point. How this cobalt 60 emits gamma rays? This is the decay phenomenon you can see here. When cobalt 59, stable cobalt 15 is bombarded with neutron, it produces unstable cobalt 60. This cobalt 60 further undergoes decay and produces 2 betas and 2 gammas. However, the 2 betas produce a very less in proportion. So, the clinically useful part is the gamma rays, 2 gamma rays produced here. And finally, the cobalt reaches to a stable position of nickel. So this is the cross section of the gamma knife unit. You can see the multiple sources arranged in a central body, surrounded by lead shielding. The different shielding methods here you can see here. And this is the cobalt source. Generally, it appears single cobalt source. How it appears like it has a triple concealed welded stainless steel cylinder in which 20 pellets of cobalt sources are placed. This is per source. The total weight of the cobalt ray is 20 grams, and the activity is 6,000 curie or 222 terabecquerel. And dose rate is 3 gray per minute. And coming to radiosurgery principle, how this appears. If you take a normal radiation percentage depth dose, we say, this is called depth and percentage dose. It's called percentage depth dose curve. For a single beam, it has a maximum dose built up at the surface. However, when you combine different beams from different direction like this, so you can build the dose at a particular center at the middle of the organ or something, and you can get the high intensity dose in the middle. At the same time, control the dose of the entrance dose and exit dose. And if you see here, for small targets, usually we use narrow beams. So advantage of narrow beam is it can highly focus the dose at the center, at the same time control the dose in the outer region. However, you can do the same thing with large targets as well. Like when you use broad beams, you can combine and use for broad beams. But however, the problem is there's an overlap. You can see the overlap, increased overlap beyond the target. So that's the difference between treating small lesions and larger lesions. How to achieve this radiosurgery principle is using small fields using collimators. So, for example, the X-knife uses this called pounds here. Linear axle uses MLC here, and model B, the old model, which used the tertiary collimator we see. Now we have the perfection model, we have the inbuilt collimator, so it's automatic positioning system. And you can see the difference between the treatment fields of conventional RT and SRS. So in SRS, you can see here how confined the dose to the tumor here. Some new developments in the gamma knife we have the frame-based workflow and the mask-based workflow. Initially, we only had frame-based, now we have mask-based workflow. So what is the difference? In the frame-based workflow, we immobilize the patient's head with a metallic frame, then perform MRI, then do a plan, and then do treatment. But however, in the new setup, you can do MRI without fixing the frame on the 1 day prior to treatment and immobilize with thermoplastic mask on the treatment day, perform a CBCT for CT reference, do a plan, and register the MRI with CBCT. And during the treatment, you make a CBCT repositioning, patient position checkup, and make corrections, apply corrections, evaluate the dose and treat. So that's the difference between the frame-based and mask-based workflow. What's the other differences? In frame-based, we do only single-session treatment. Mask-based, multiple-session treatment. Tumor diameter usually 3 cm for frame-based, and volume is 25 cc. And mask-based tumor diameter usually greater than 3 cm, volume greater than 25 cc. And frame-based is invasive technique, whereas the mask-based is non-invasive thermoplastic technique. Here, the X-ray coordinates are using through indicator boxes. However, in mask-based system, we use the high-definition motion management camera and reflectors in the adapter to get the fiducial and the stereotype coordinates. And usually dose per fraction is larger in frame-based, whereas the mask-based gamma knife, dose per fraction is lesser, 5 gray at 50%, for example, and given in 3 to 5 fractions. Thank you.
So I would like to start with a brief description of evolution of gamma knife at AIIMS. So Professor A.K. Banerjee and Professor V.P. Singh were the pioneers of gamma knife at AIIMS. We started with Model B, which was installed in 1997, which had only two collimators available, 14 mm and 18 mm, which had to be manually set between every shots. This significantly increased the treatment time. Then came the perfection model in 2011, which allowed automated collimator arrangement of 4, 8, and 16 mm, which could be used in combination to produce a more complex treatment volume and decrease exposure to structures outside the targets, and hence decrease the treatment time. Currently, we have the newer model, which is the ICON model, which was installed in 2022, which permits frameless treatment and comes with an attached CBCT apparatus, which can be used to define the stereotactic space. So the daily workflow of Gamma Knife Center begins with a frame fixation. The accuracy of the treatment system is of paramount importance and for safe and effective delivery. Rigid immobilization is the gold standard for ensuring that the target is within a defined stereotactic space. Frame includes a base frame. This is the base frame with 4 posts, and each post has a space for the screw through which the screw can be inserted. We apply local anesthesia at the points where we will insert the screw. We also have newer frames available. This is the Vantage frame, which is lighter and more patient friendly and lacks the mouthpiece, and this allows intubation in cases of emergency situations. And this is the frame-based treatment which is being given to this patient. Mask-based treatment which is being given to this patient. We use mask-based treatment for patients with multiple lesions which require multiple sittings or large lesions which require fractionation. So once we have fixed the frame and we have ensured that the target falls within the center of the stereotactic frame, we proceed with imaging. So there are two ways we can go about imaging. MRI can be obtained either on an earlier date and then co-registered with the reference CBCT, which is done on the day of the treatment post frame fixation, or the MRI can be obtained with the frame on the day of the treatment. This will help us in defining a stereotactic reference. Also, for our cases, for the cases of AVM, we can get angiography done with the frame fixed, and then this will help us in angiography guided nidus marking. Once we have obtained the imaging, we go ahead with the planning. We retrieve the images from packs and we define the target structures and structures at risk. For example, in this case, we have defined the target, and as you can see here, we have marked the visual pathway on the right and the left side, and these are the structures at risk to which we want to avoid giving excess dose of radiation. Then we create various plans to achieve desirable values of various indices, which is as follows. So first we set the coverage, which is the fraction of the target volume that receives at least the prescribed dose. The other index that we need to check is the selectivity, which is the fraction of the planning isodose volume that includes the target volume. We try to achieve a target coverage of more than 0.95 and selectivity of more than 0.8. The technical challenge that we face is that both of these are inversely related, and a delicate balance needs to be maintained between the two. We try to keep the beam on time to as minimum as possible to reduce the treatment duration. Once we choose the most desirable plan, we use the Lightning software to set the prescription dose for the target and the maximum dose that is going to be delivered to the axis. Like for in this case, it is the left and the right. The plan is also approved by a radiation oncologist and physicist, following which the treatment is delivered. This is a graph representing the total gamma knife cases that have been done over the years. Contrary to the West, our major bulk of cases is formed by benign lesions such as meningioma, vestibular schwannomas, or pituitary macroadenomas, both functional and non-functional. We give primary gamma knife lesions which have not been treated before, and secondary gamma knife in lesions which come with residuals or recurrence post-surgery or embolization. The total cases that were done in Model B from 1997 to 2010 were 2,590. And the perfection model was 2000 perfection model that was there from 2011 to 2021, 2,991, and from 2022 to August 2024, we have done gamma knife for 1,858. I would like to invite Dr. Manoj and Dr.
So now we'll discuss something exciting, the clinical applications, which is this real scope of gamma knife radiosurgery. And a fun fact, the eye blinks almost 1,000 times per minute. Maybe in a day it blinks around 16,000 times while you are awake. And the precision of the whole treatment, the high conformability and everything is dependent upon immobilizing a target. So Dr. Gursevak will take you through the various kind of lesions which we have treated and the future perspectives which we are looking at.
Thank you, sir. Good afternoon, everyone. Now that we have discussed about stereotactic radiosurgery, its scope, it's apt to discuss the scope. From its proof in 1949 by the Swedish neurosurgeon Lars Lexell till the first clinical application in 1968 and till date with the latest ICON model, stereotactic radiosurgery has grown leaps and bounds. Due to its range, precision, and millimetric precision, it has soon become the favorite of neurosurgeons world over wherever it is applicable. It's a common knowledge that gamma knife stereotactic radiosurgery can be applied for benign lesions, including vestibular schwannoma, meningiomas, malignant lesions like multiple intracranial metastases or ocular malignancies. Apart from that, AV malformations and cavernomas. But what we are going to discuss is some well-known indications where we are expanding our horizon, some indications where our latest evidence is coming up, but we still are in the process of getting data and to analyze whether it is beneficial for a long term, and some rather controversial indications where there is no clear-cut evidence that it is better to other modalities of treatment. Coming to benign conditions for vestibular schwannoma, the main aim of the treatment is hearing preservation and preservation of the facial nerve function. As far as surgery is concerned, only 1/4 of the patients are able to retain a serviceable hearing, as against about 94% for gamma knife radiosurgery, where it is offered as a primary modality of treatment for smaller lesions. Coming to the large vestibular schwannomas, today, the main emphasis is there on planned subtotal excision with secondary gamma knife surgery, which offers up to 98 to 100% facial nerve function preservation, as against about 58% where primary surgery was offered at an earlier date. Also, we are expanding our horizon to treat cystic vestibular schwannomas, which were earlier considered as a relative contraindication for giving gamma knife surgery. As far as skull-based meningiomas are concerned, in the words of the neurosurgeon Dolink himself, who is considered as a pioneer in skull-based meningioma surgeries, and there are approaches and many texts given by him for the skull-based approaches. He himself, in his book in 2008, told that gamma knife can be the future method of treatment of skull-based meningiomas. And as he has rightly pointed, so these days a lot of skull-based meningiomas are being treated with gamma knife radiosurgery with a good progression-free survival. Also, for atypical meningiomas, where patient has undergone multiple surgeries and also received external beam radiotherapy with recurrence, gamma knife is a viable option to treat and has shown a good progression-free survival for a long follow-up of about 6 to 7 years, as depicted by this case. And we can see on the serial follow-up scans that there is no progression of the disease. And after 7 years, patient had come to us with showing some progression, for which he is again being planned for a redo gamma knife surgery. AV malformations were earlier treated surgically, and we had option of surgical excision with time, embolization, and also gamma knife surgery for smaller lesions. But for the larger lesions, Spitzer-Martin classification 3 to 5, we really had no treatment to offer on the earlier dates. But with the advent of volume staged or volume fractionated gamma knife stereotactic radiosurgery, nowadays we are able to treat large AV malformations, so much so that on a follow-up of a 3 years, there is virtually no nidus which is left, and this AVM is considered treated completely. Also, the lesions which were earlier considered inoperable because of the involvement of the critical structures of the brain are now being increasingly treated with the gamma knife surgery. And as we can depict in this case serial wise, image number 4 shows only a small residual lesion in the thalamus, which is now being planned for fractionated gamma surgery for the 5th time. So this lesion over the past 7 years has reduced considerably in its volume. Gamma knife is not only limited to benign diseases, we can also manage malignant diseases with gamma knife. Some well-known indications are multiple synchronous intracranial metastasis, where earlier the surgery was considered the only viable option. But nowadays we are treating synchronous intracranial metastasis with fractionated gamma knife. And this case, we had treated almost 16 lesions in a case of metastatic CA lung, and over a 3 years follow-up period, patient shows almost complete resolution of more than 50% of the lesions. Not only malignant and the benign conditions, or maybe the vesical lesions, we are also now going into the era where we can think about giving gamma knife radiosurgery to the functional disorders as well, like in limited cases of epilepsy, where surgery is either not possible or it is not desirable by the patient. So we can plan gamma knife, though this is a procedure which is not being done routinely, but in select individuals we can offer. The main criticism or the main disadvantage being the optimum control and the time taken for the effect, which is to the tune of 1 to 2 years. Similarly, a case of Parkinson's disease who had drug-induced dyskinesias and DBS was not feasible because of bilateral ectatic PCA, and the loops were coming into the trajectory for DBS, was planned for GK pallidotomy and is now under follow-up with good symptom control. Now venturing into some controversial indications where the evidence in the literature is equivocal, coming to the high-grade gliomas as primary or the secondary modality for control. This is the case that was operated about 1.5 years back, high-grade insular glioma with small residue, and it was decided to give a secondary gamma knife, and now a patient is on a 1.5 year follow-up, shows progression-free disease and is still under follow-up. So these are the further directions where we can think about or which we can explore. Pain modulation is now, we are at our center only exploring trigeminal neuralgias and glossopharyngeal neuralgias as far as pain modulation by stereotactic radiosurgery is considered. But there are many other indications which are under evolution at a global stage, and slowly, probably when the data or the evidence is sufficient, we can probably consider to expanding into these indications regarding malignant pain or spine injury related pain and the post-stroke pain syndromes. At the global stage, gamma knife has been explored for head and neck cancers, obsessive compulsive disorders, and essential tremors. But these are still at the developing condition, with every indication being having its own set of indications and contraindications. But we do have some experience of managing ocular malignancies in consultation with our peers at ophthalmology department. A case of uveal melanomas. We have almost managed about 10 cases with good vision preservation. So far, so that primary gamma surgery is now considered as a gold standard for vision preservation in cases of uveal melanomas. So as we can see that we have managed to take almost all the indications of gamma knife surgery which are existent as on date, with the exception being probably behavioral and psychiatric disorders. And the next big leap will be to manage head and neck cancers, obsessive compulsive disorders, and lesions, including the high cervical cord benign conditions. With this, I would like to call upon Dr. Akshay Ganesh for discussing about unforeseen outcomes and the complications of stereotactic radiosurgery.
Thank you and good evening. As shown before, gamma knife is a powerful weapon in the armamentarium to treat many lesions, but it is a double-edged sword. And what I will be presenting here is the cases where it has been used. A 40-year-old male came to us with history of seizures since 1 year, and he was found to have a left medial temporal Spetzler-Martin grade 5 AVM, for which primary gamma knife was given in June of 2023. He came back to us almost a year later with breakthrough seizures and progressive contralateral hemiparesis, which was because of perilesional edema. The AVM in this case was residual, and he was put on medical management for the edema. His seizures abated, but he left with fixed neurological deficits. So this is a case where medical management of the unforeseen outcome could save the patient. This 45-year-old female had come to us with history of headaches, and on evaluation was found to have an anterior 1/3 falcine meningioma, for which primary gamma knife was given. Almost 4 years later, on follow-up scanning, the patient remained asymptomatic, and there was good lesion control with reduction in 90% of size of the lesion. But there was perilesional edema. So this is a case of a asymptomatic idiosyncratic radiological unforeseen outcome, whereas the patient remained clinically stable. This case illustrates that not all problems associated with a lesion can be tackled with gamma knife alone. A 54-year-old female came to us with progressive left-sided hearing loss and tinnitus, was found to have a left-sided vestibular schwannoma. There was radiological hydrocephalus at presentation, but the patient was asymptomatic for the same. Primary gamma knife was given. Almost 9 months later, the patient presents to us with symptoms of raised ICP and still persistent radiological hydrocephalus with papilledema on fundus evaluation. So the patient underwent a right-sided ventriculoperitoneal shunt CSF diversion procedure, which abated her symptoms. There are limitations to gamma knife as well. For example, lesions which extend below the C2 vertebra or in the high cervical region, they cannot be effectively targeted by gamma knife, as seen in this case of a left-sided lower cranial nerve schwannoma, where the untreated lower pole of the tumor has progressed in the follow-up scan 9 months later. This is an interesting case. This is not directly attributable to gamma knife itself, but a case of posterior 1/3 falcine meningioma was given primary gamma knife. The lesion is follow-up scans show that the lesion is under control, but unrelated anterior 1/3 near parafalcine lesion, which is cavernoma, has appeared in this case. So it is essential for us that unforeseen outcomes can be radiological and even unrelated to gamma knife. So one must keep all senses open in the follow-up scans. This is an unfortunate case. An 8-year-old child, unrelated to gamma knife, had a complication. There was a right-sided cerebellar AVM and idiosyncratic reaction of radiation necrosis and rebleed in the residual nidus 5 years later. Led the child to to present to us with altered mental status and altered breathing. The patient underwent an emergent surgical decompression, however, could not be salvaged. This work done in our department, again building upon the unforeseen outcomes, is a series of 921 cases of AVM which have been treated via gamma knife. 8 out of these patients developed cysts close to the lesion, with either 3 of them had angiographic resolution of the nidus and 5 of them still had residual nidus with cyst formation at the place of the AVM. This is one of those cases. All 7 of the patients underwent surgical treatment for the cyst. This patient had a right parieto-occipital AVM, large AVM, underwent primary gamma knife, and there was perilesional cyst formation with complete resolution of the nidus angiographically. The patient had presented with symptoms of raised ICP or intracranial pressure, underwent craniotomy and cyst fenestration, and the patient left without any deficits. So unforeseen outcomes can occur even with lesion control. Some literature on the controversies regarding the scope of the lesions in which gamma knife can be applied. Hemorrhagic brainstem cavernomas. Cavernomas are low flow vascular malformations which are either usually treated surgically or they are treated with conservative management. Gamma knife usually is not an option for cavernomas. However, this group has applied gamma knife to cavernomas. The reason is patients who are not surgical candidates for cavernomas can be managed with conservative management. Giving up gamma knife in such patients, what is the risk to benefit ratio is still unclear. And this paper concludes that adverse radiation effects with low dose gamma knife is still low, but what is the benefit of giving gamma knife in such patients is still unknown. Arteriovenous malformations which have flow related aneurysms in their feeders, such patients have classically been advocated for direct surgical or endovascular management, not radiosurgery or gamma knife. This group has done a cohort study, observational cohort study, where it has been found that yes, unsecured proximal aneurysm should be obliterated before radiosurgery or at the time of resection. So gamma knife does not have still a scope in this patient group. As portrayed earlier, high-grade gliomas are still an evolving field, stereotactic radiosurgery in high-grade gliomas, and this group has compared the effect of gamma knife combined with conventional radiotherapy versus only conventional radiotherapy in glioblastomas, and has found no benefit in either the cognitive functioning, quality of life, or even overall survival. So still this is a evolving field and a controversy. With this, I would like to call upon Dr. Veda to present on the publications of our department in gamma.
Thank you. Good evening. AIIMS Delhi AIIMS Delhi has been on the forefront of research and development in microneurosurgery as well as stereostatic surgery since the inception in the late 1990s, with a steady rising trend of publications in its back. The number of publications coming in from AIIMS Delhi have been diverse in nature, encompassing all the segments of stereostatic neurosurgery, spanning from tumors such as vestibular schwannoma and meningiomas to vascular malformations in form of AVMs. With the rise of publications in the recent few years, probably credited to the recent acceptance of SRS to manage many complex neurosurgical conditions and its broadening spectrum to include more and more diseases. The steady rise in publications over the years elicited gamma knife's acceptance into the armamentarium of a neurosurgeon. We would like to take this opportunity to highlight a few of the notable publications that have been instrumental in setting the stage for the use of SRS. Our first article for today is the following retrospective study on tumor control and hearing preservation after gamma knife radiosurgery for vestibular schwannomas in NF2, published in the Journal of Neuro-Oncology in April 2010. Its objective was to analyze the effect of gamma knife radiosurgery on tumor control and hearing preservation rates in the patients of vestibular schwannoma in NF2. In our institution, 9% of the total gamma knife recipients are NF2 patients, with mostly getting bilateral vestibular schwannomas treated in the same setting. The radiological imaging on the screen showcases the sequential contrast MR imaging required during treatment and follow-ups. The images depict a serial central decrease in contrast enhancement in both tumors, accompanied by overall decrease in tumor size. This study concluded that tumor control rate, radiologically 87% in 27 months and 67% till 5 years, is seen in the Kaplan-Meier curve. It also concluded 66.7% of hearing preservation rate in those patients with useful hearing prior to the procedure, hereby setting a precedent for using gamma knife vestibular shock. Coming to the next, the following non-randomized case control study on draining vein shielding in intracranial AVMs using gamma knife, published in Neurosurgery in January 2015. It was postulated early draining vein occlusion is to be one of the reasons for hemorrhage and edema in intracranial AVMs. Hence, it was hypothesized that decreasing radiation dose to the draining veins may prevent the early draining vein obliteration, leading to decrease in complications. The following study showcased because of shielding, the test group patient received significantly less radiation to the draining vein and in follow-up showed significantly less complications. The article thereby presented shielding of the draining vein as a potent new strategy in minimizing complications following gamma knife in intracranial AVMs. Just briefly, I would like to speak about this recently published article in World Neurosurgery in July 2024. RICs are the most common complications observed post-gamma knife surgery, and it has been observed that almost 1/3 of the RICs are symptomatic and half of them are persistent. There lies the mystery, as there is no way to predict which patients will develop these changes and if they do, to what extent. To solve this ambiguity, the following pilot study was performed with the aim of understanding the role of VEGF and endostatins as a predictive factor for clinically and symptomatic RICs in SM grade 3. Serum biomarkers could be used to identify at-risk cases. However, more research in this field is required. Coming to a very interesting article published in World Neurosurgery in 2023. As discussed, with all the advantages that have been previously discussed for gamma knife therapy, the most significant downside is its cost. An average Indian family survives on a 10,000 per month salary, and the cost of gamma knife in private sector is 6.5 lakhs per case, which is around 650 times. Owing up to this problem, the following pilot program was implemented in AIIMS in April 2015. Under this policy, the patients were asked to pay the existing charges of 75,000 upfront and their entire treatment fee that included gamma knife procedures and all follow-up MRIs through their life were covered. The following study highlighted the dramatic increase as visible on the graph on the number of patients that got gamma knife after the implementation of gamma knife for life. Gamma knife for life therapy thereby is paving a way for other centers in the country to adopt this strategy and instigate policymakers to come up with new ways and means to enhance the access of gamma knife in various parts of India. Now I hereby call upon Dr. Kamaldeep Garg for this quote.
Good afternoon, everyone. Thank you, Vedant. Now I'll go through a few new things which we have developed over the past few years. So, as a referral center, we are frequently confronted with patients with large AVMs. Such AVMs cannot be excised safely. And if we have to treat such AVMs with a single stage SRS, then we will not be able to deliver the required dose, which is required for obliteration. So in such cases, we have developed a strategy of volume fractionation, fractionated SRS, in which we divide such large AVMs into multiple small parts and treat them as if an individual AVM. This is an example of a young lady who presented with just seizures, and she received the SRS in 4 fractions. This is the last MRI. And there's a very small nidus which is left, and she's neurologically intact. Traditionally, we used to get MRI and DSA both on the day of gamma knife after frame fixation to delineate the nidus. But over the time, we realized that if we use high quality MRI, which is available these days, to delineate the nidus, then we are doing equally good job. And we compared our data in which we made 2 groups, and we found that the AVM obliteration rates in the group which underwent SRS based on MRI alone as compared to MRI and DSA both, the obliteration rates were the same as were the complication rates. Now, with the easy availability of MRI, we get many patients who with incidental findings of MRI. Most common among these are dural-based lesions. So, such lesions are small. They are planned for primary SRS The biggest problem in such cases is that we don't have any histopathology available. For example, if we are treating a dural-based lesion, it may be a grade 1 meningioma, or it may be a high-grade meningioma, or it may be some other pathology like fungal lesion or something else. So to help us in such situations, we are taking the help of AI to create gold standard medical imaging database of dural-based lesions. It's a project along with IISc. It's a multi-phasic project. There are 5 phases. Currently, we are in the phase 1, which involves extraction of brain tissue. Uh, Firstly, we will use the patients who have undergone surgery, and we have the histopathological data available with us. In the further phases, we'll apply these to the patients who are undergoing primary SRS, and hopefully this will be helpful for us. Now, I would like to invite Professor Kali for his remarks.
Good afternoon, everybody. So I've had the fortune of being associated with this Gamma Knife at our institute since its beginning. So now it's 14 and 4 and 22. So it's almost 28 years since I've seen and done Gamma Knife on 3 different machines in the last 28 years. The machines have evolved. The time taken for treatment has shortened. The indications have increased. And that has led us today to, I think, what, 9,000 patients we have treated? Almost 9,000 patients we have treated on Gamma Knife successfully. Well, not all successfully, as we saw some of our complications. But overall, I think it has been a remarkable tool in the hands of neurosurgeons. Remarkable. I mean, the amount of morbidity and mortality which has disappeared because of the invention of this tool is just fantastic. I mean, I've straddled neurosurgery from the old times to this time, and I can just imagine the bags and liters of blood which we have saved, if nothing else. So I think it's a fantastic tool which, thanks to the institute and thanks to our government, was the first one to be installed in the country. And in the last 28 years, I think it has served us very well. Thank you for your attention. Any questions? We are all here to answer. Yeah. So the biggest limitation is the size. You see, the idea of doing this Gamma Knife is you give radiation in one shot. So it has to be a whole lot of radiation. So sometimes for an indication like rising, we give 50 grade, 60 grade, not shot, to kill the nerve so that the pain doesn't. So the volume has to be exquisitely small. But if you have a area and the size which was shown, giving that much radiation to a volume of 100 cc is so the biggest limitation is the size. But we are trying to overcome that size by doing volume. And with the new mask and all, we can have the same accuracy. But there was a frame-based garment. To keep the frame on for 5-6 days, it's terrible for the patient. But now the technique has evolved to a mask-based thing. So we can reproduce the same accuracy in 5 different days in the same patient. That helps us to do large numbers. However, we are still not sure about the application of Gamma Knife to the most common tumor which occurs in the brain. Still don't know. And the majority of the people who get operated because they're extracting, we don't come to unless they. So we still don't have a Gamma Knife application. Either a Gamma or for a Gamma.
long-term complication. Radiation and
Yes, there are issues. Yeah, sometimes we get radiation-induced tumors. I think, did you show that example of radiation? So sometimes radiation to one part of the brain induces a tumor. So it's a double-edged sword. However, overall, I think the amount of benefit it has given far outweighs these complications or adverse effects. So I thought it was a good time to just review what we have done. I myself was amazed at the results. 9,000 patients is a lot. Yeah. Nothing. In fact, if you have small metastases, the number doesn't really matter. There usually 30 metastases in the brain without much problem. But if it is a single large lesion, giving so much radiation to a large volume, that is what creates. Right? Well, the only thing if you do is steroids, because it causes a lot of edema. So steroid helps reduce the edema. And in some patients of this malignant kind of edema, we have given elastin. We have given elastin. That helps. Of the normal brain. Because in the lesion we want. No, that's the beauty of the government. The dose follow around the lesion is so remarkable that there is hardly any problem outside. Okay, thank you. Yeah, last question.
So what is the future of
I think Gopi would you like to take this question? Why do we still go with gamma knife? Why don't we shift to X knife or
Gamma is still relatively all that's what are the people. We only wear
so there are you saw earlier slide there are two or three ways in which you can use the stereotactic. One is to use X-ray, second is to use gamma rays, and third is to use those heavy particles like proton. So there are some tumors which respond exclusively to proton beam. For example, podoma. Podoma just melts with proton beam. But gamma knife or X-ray doesn't have much effect. So even now, as we speak, they're still studying the biological effects to decide what is good for what. It's still evolving. And in this country, I think we have one proton beam. Two now. Only two now. And we don't have one in India. So it is coming. I think in the next few years and decades, we will exactly know what is the or ways which you use. But as far as intracranial lesions are concerned, there is nothing more accurate than that. So the cyber knife and the X knife were discovered to lesions which are in the moving parts of the body. For example, in the lung, lesions in the lung. You know, to move with every breath, the lung expands, contracts. But you want to give radiation to the lung. So you have that cycle manifestation. Move with every movement of the body, you can move activity. While gamma is there, fixed volume, surrounded by fixed cell, nothing is moving. So gamma knife accuracy is just much better than all the other knives. So it's like that they all use multiple strategies. The problem with cobalt is the advantage of cobalt is you can deliver a whole lot of dose.
Immobilization. But again, since it is moved to mass, immobilization was the main
Because the lesion inside the cell, so it gave us very good but now the patient comfort is and the screw going into the cell